Kelihatan sekarang?
Jelas, Dok?
Ya.
Izin Dokter Ria, kami mulai.
Boleh.
Oke. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning to all the participants, to Dr. Sri Martani, Dr. Shih-Chi, Dr. Ceva, and Dr. Dita. Welcome to NTUH Mangunkusumo Hospital Joint Webinar Series Episode 3 with the title, The Critical Care in COVID-19, Intensivist and Pulmonologist Point of View. And this webinar series is a continuity, actually, and will be conducted for approximately 5 episodes. And before we proceed to the next session, there will be an opening remarks from Dr. Sri Martani as the Director of the Human Resources, Education, and Research of Cipto Mangunkusumo Hospital. Please, Dr. Sri Martani, the session is yours.
Okay. Good morning. Assalamualaikum warahmatullahi wabarakatuh. Greetings all. And first of all, on behalf of the CEO of RSCM, Cipto Mangunkusumo Hospital, I would like to greet all faculties, Dr. Shih-Chi as the Director of Respiratory Care Center and Critical Care, Dr. Ceva, Wicaksono, Pitoyo, the Head of Division Respiratory and Critical Care Department of Internal Medicine, Cipto Mangunkusumo Hospital and Faculty of Medicine, University of Indonesia, Dr. Dita, Aditianingsih, the Head of Intensivist Care Unit, Dr. Cipto Mangunkusumo, and Medical Staff Department of Anesthesiology and Intensivist Treatment, Faculty of Medicine, University of Indonesia, and Cipto Mangunkusumo Hospital. And of course, to all webinar participants. Well, welcome back to the NTUH-RSCM joint webinar series this morning. Our third episode of collaboration topic is on the critical care in COVID-19, intensivist and pulmonologist point of view. We dedicate to discuss this hot issue because physicians frequently encounter with numerous cases up to severe and critical COVID in clinical practice. To our best knowledge, lungs are well-known target organ in COVID-19 patient, and the clinical spectrum is quite variable, varying from mild, moderate to severe and critical. Besides the high number of severe and critical entity of COVID-19, other reason we choose this topic is because its management is continuously evolving and there are many questions arise and to be answered. For example, in respiratory failure due to COVID-19, what kind of ventilation works best? Non-invasive ventilation or invasive ventilation? Should we proceed to early intubation or not? What about prone position in intubation patient? Is it beneficial? In critically ill patients, should we also administer anticoagulant? Of course, there are more questions beyond those that we mentioned above, and this webinar would be a perfect place to find this answer. We believe that we will have a fruitful discussion on this topic, and all participants will gain useful and practical knowledge from all faculties. Before we proceed to this scientific session, once again, I would like to express our sincere gratification to NTUH faculty, Dr. Shih-Chi, all the NTUH committee, also to Dr. Ceva, Dr. Dita as a faculty from Cipto Hospital and whole RSCM committee. We hope that our collaboration will be sustainable for many years to come and find today webinar interesting, enjoyable, and beneficial for our patient and to our knowledge. Demikian, selamat webinar, bersimposium. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Sri Martani, for your opening remarks. And now we will proceed to the scientific session with the moderator, Dr. Ceva Wicaksono Pitoyo, and the faculties, Dr. Shih-Chi and Dr. Dita Aditianingsih. Dr. Ceva is currently the head of the Respiratory and Critical Care Department of Internal Medicine, Faculty of Medicine, University of Indonesia, Cipto Mangunkusumo Hospital. To Dr. Ceva, please, the session is yours. Okay, thank you.
I mean, the condition now is we have a very high problem of COVID-19 that we are going to discuss and share experience on how we treat COVID-19, especially in the severe condition in the critical care. Thank you for the attendance for everybody here, and especially for the speakers of the faculty. There will be Dr. Dita Aditianingsih, our anesthesiologist from RSCM, and she's intensivist since 2010, I think. Yeah, she's now had the intensive care unit in all intensive care unit in Cipto Mangunkusumo Hospital, and she has a lot of work, I think, in critical care in transplant, yeah, organ transplant in Indonesia, and now she's also in charge in the critical care of COVID-19 patient in Cipto Mangunkusumo. And we are going also to have our honored Dr. Shih-Chi or Dr. Simon, right, from Taiwan University Hospital, and he's a deputy director also of residency training program internal medicine in Taiwan University Hospital, and also is now director of medical intensive care unit there, also the director of respiratory care center. Okay, without further ado, I think because the time is running, I would like to let Dr. Ku to talk about the managing COVID-19 patient with acute respiratory failure. So, Dr. Ku, the time is yours.
Okay, thank you for your kind introduction. Can I have a slide, please? So, okay, you can see my my talk today. Well, the management of COVID-19 patient with acute respiratory failure. We know that the patients with severe COVID-19 usually present with acute respiratory failure. So it's a critical issue. I think the moderator already mentioned what about the timing of intubation of this patient and how to, before intubation, how to manage all these patients. I think it's a critical issue. Depends on the mass search of a critical ill patient and how to management. I think it's a very important issue. This is the data I achieved this morning. So you can see that almost 25 million patients in the world and almost 830,000 patients die. And I also point out here is the data from the United States. So almost 6 million patients. But you can see that case fatality rate around 3 to 3.4%. Maybe you think the number is lower, but you think about all the patients around 5% will present you with severe cases. So you can do the math. You count the 25 million patient times 5% patients. So it's a critical ill patient if present in a short period of time. It is a great impact on the for the healthcare system in every country. So I think it's a very important issue still in the public health and all over the world. So my lecture today is a reference from all these guidelines. I think you can reference online. First is from our Taiwan Society of Pulmonary and Critical Medicine. You can access online. And another is from our Taiwan CDC, the interim clinical guideline for a SARS-CoV infection. If other sources from other country, from the Brigham and Women Hospital, I will highly recommend it. You can access this because they updated the guideline content. I think it's a very real-time way, so you can always access on this website to get update information. And then another is surviving safety campaign, and the interim clinical guideline from the United States CDC, and another from the American Thoracic Society. And look at this. It's the interim guideline from our Taiwan CDC. They have an English version, so you can access this and look at the content. I think the content is from our expert in our country and combined with other sources from all over the world to get this version. And this is, I mentioned the Brigham Women's Hospital. I think it's very useful tool. So always look at this website, and you can look at here the many items you can click in, and there's the content. And always there's a content with some reference, and this reference is updated. So I will highly recommend it. You can access this protocol online. And this is from the Surviving Safety Campaign. They have a specific topic for the COVID-19 guideline. And this is from the United States COVID-19. And I think it's a little bit not so updated. Maybe they update the information once per month or etc. So you can also access online. And so when we talk about the COVID-19 patients, we should have the same definition of the severity. So it's from WHO classification. You can see here they define the mild illness, especially is only upper respiratory tract viral infection. So maybe mild symptom, non-specific, fever, fatigue, cough, etc. Maybe they present with a general malaise or nausea, and some extrapulmonary presentation. We were well known that diarrhea or some loss of smell or taste. But if we look at the real issue is the pneumonia. So first part is you have the above-mentioned respiratory symptom, but you have a chest X-ray infiltrate. But here, if we talk about only pneumonia, not severe pneumonia, then we talk about they don't need for supplement oxygen. It's very important. So maybe they have a symptom, they have a chest X-ray presentation, but in general, it's not so severe. So we define do they need supplement oxygen? But we go further to the severity. The severe pneumonia is very important. Above mentioned symptom, fever, chest X-ray, but very important. They got in the room air. The pulse oximeter is less than 93%. So we have a same definition. If we talk about this patient is a severe pneumonia, then for definition pneumonia, and you pass, especially the oxygen demand increase. So in this situation, you need to supplement these patients with oxygen. And then the definition from the child, I think in general it is some definition we take about the baby, they have a rest symptom or conscious, etc. And when you go further to the very severe form of COVID-19, it's ARDS, acute respiratory distress syndrome. So the definition is established since the 2000 around 12. So it's organized definition, especially if you got a severe pneumonia and the oxygen demand. We can, from this definition, you can look here, is the PF ratio from the PL to oxygen content divided by inspiration fraction of oxygen. Then the ratio is around, we know three criteria, 300, 200, and 100. So especially if you talk about severe ARDS, the PF ratio is less than 100 millimeter mercury. So if you, the patient, admit to the intensive care unit and with a definition of pneumonia, confirmed cases, and the oxygen go into the ARDS criteria, then we should follow the treatment recommendation for ARD. I will talk about it later. So let's talk about the patient with respiratory distress. And I think it's a very good summary of all the patients with COVID-19 with hypoxemia, hypoxia, and you can look at the flow chart. And I think you can access online from the Surviving Sepsis campaign. They have an infographic summary. So I access this and present to you. So if patient got some problem with hypoxemia, it's always think about the indication of endotracheal intubation. So I think it's very important issues because there's some concern about the spread of the virus for the healthcare professional. So it's very important if this patient got a criteria of intubation, then you need to do right away because of concern about patient safety, patient's health, and especially the safety about the personnel care of this patient. If they got indication for endotracheal intubation, so go for here, prepare intubation, and find the expert to intubate. So in our country, in our unit, if the confirmed cases need to intubation, we always search for the expert, especially anesthesiologists. They have plenty of experience to intubate because of high risk of patient. And here is very important for the personnel. They need to prepare for the PPE and for infection control precaution, and some very important minimize step in the room. And here is mentioned for the laryngoscope. Here in our medical intensive unit, we already have this device to video assist laryngoscopy. But if not indication for intubation, you can go here, then need to supplement oxygen. So about the target, and I think if less than 90, you need to supplement oxygen to raise the level to 92 or 96, and especially always look about the infection control precautions. And here, if they oxygen is did not need the simple oxygen supply is not did not need the needs, then you do go further is high flow nasal cannula. And here again, always look about the indication of intubation. And here you can go further. Is here is mentioned about the trial of non-invasive passive ventilation. But I want to mention here is because the patient, if they already in the isolation, negative pressure isolation room, that's fine. But if they did not already in a maybe some large area already have other patient, and there's a concern about use the NIPPV because the spread of the virus of the droplet. So it's very, very important when you can maybe consider trial NIPPV, but in the same time, should very, very concerned about the infection control measure. Here again, do not delay intubation because you try NIPBV. So some patient, maybe the timing of intubation may be delayed. It will be the worst outcome for all these patients. So for the some pneumonia, it's very non-specific pattern. So I think you cannot tell from any specific chest X-ray pattern to differentiate COVID-19 or non-COVID-19 patient. Always think about contact history, presentation, etc. And maybe there is some information about CT scan, but I think it's still not specific and depends on the exam accessibility and some infection control measure. So I think from by CT, chest CT to differentiate or define the severity is, I think it's impractical in the clinical practice. So the first clinical management is oxygen. So here initially we use the nasal cannula. So you can use the oxygen for 5 liters per minute, and the target divided by pregnant and non-pregnant. But for the pregnant, you should raise, you should set up your level higher because concern about the baby. And for the SARS-CoV patient, we should cross monitor. So use the device pulse oximetry, and if available, you can single use the device, especially nasal cannula, simple mask, non-regressing mask. It's very important. You cannot cross use them from different patients. It's always under the consideration of the concern or spread of the virus. And if further needed, we can try the non-regressing mask. Because simple mask or non-regressing mask, we didn't use the humidifier device because always a concern if the device contains the humidified air, then when it's come out to the contact patient, maybe spread out to the contamination of the environment. So if oxygen demand increase, we further use a non-regressing mask. Here is the flow around 10 to 15 liters per minute. The target around the target is very oxygen fraction is 0.9 or to the 0.6.9. And here this is a device of high flow nasal cannula. Let's talk about. I know there's some issue about around the world. They always consider use this device, but I still mention because it's a high flow and it's a little bit oxygen humidified air, but it's more the weight is coming to the nasal area. So still maybe some concern the spread out of the droplet. So maybe you can use it, but always consider the impact for the environment or the personnel who care this patient. And here is I mentioned about do not recommend is in general do not recommend this non-invasive ventilation. But I know if in some area, especially maybe the invasive ventilator is not so available everywhere. Yeah, some institution will consider use this NIPBV. But I think it's very important issue is if the timing of delayed intubation or the timing of or the issue of impact the environment. So I think it's very important for these two parts, high flow nasal cannula and NIPBV. I know in Italy there are some published data mentioned. Okay, they try to use NIPBV and improve the patient. But I think it's the different scenario under the mass surge of a critical care patient. Maybe there's no way that you need to consider or use the NIPBV first. And further is if a patient, SARS-CoV infection patient, they got rapid deterioration. There's no doubt and intubate this patient, and with shock or multiple failure, you just follow the guideline from the management of sepsis. And especially the nebulizer here, talk about if the patient needs some nebulizer, it's very important, you know, when you nebulize the patient, the humidified air will come out here. They spread all over the room. It's always concern. If not into the negative pressure room, you should minimize or prevent use of nebulizer. If it's possible, some bronchodilation, we will use this meter dose inhaler. Then you use this holding chamber and the mask to the patient and minimize the contamination of the environment. And the patient without shock, it's very important we follow the guideline of sepsis and we use the conservative management. But if the patient with shock, some antiviral therapy here mentioned is maybe in Taiwan, we will follow the clinical trial of remdesivir. So we for some patient maybe we have available of this antiviral therapy. About the empirical antibodies is very important. Sometimes the issue about co-infection of the COVID-19 patient is always raise the issue. So sometimes for our patient presented with shock, we usually use the antiviral therapy and the empirical antibodies. And later on, we assessment then decided keep on the antiviral. But the empirical antibodies, if there's no evidence, maybe 3 days later or 3 to 5 days later, we will discontinue the inferior antibodies. Then we go into the severe form, the patient with ARDS. And I think it's a very important challenge for our intensive care intensives. And also, I access from a surviving sepsis campaign, and I think it's a very summary information about the patient with COVID-19 and ARDS. But I think in general, all the principle we will know is always follow. I think from the clinical trial for ARD patient, maybe 20 years. I think the general principle didn't change. Even you are care the patient, severe ARD patient with COVID-19. And as I mentioned before, they divide it by mild to moderate, or down to some ARDS. For the mild ARDS patient, I think if they are intubated, they follow the low tidal volume. So the range is about 4 to 8 cc per kilo ideal body weight. The plateau patient is less than 30 centimeter water. And especially the bacterial infection, I mentioned co-infection, if the patient got severe pneumonia, COVID-19 pneumonia, and progress into the ARDS, we always think about the concern of bacterial infection. And even I know some literature already mentioned about Aspergillus. We well known, especially for the flu, severe influenza ARDS patient sometimes combined with a Aspergillus infection. And I think it's raising important issue for the severe COVID-19 with ARDS. And the target is around the CO2 is here. And if the patient didn't have septic shock, always a conservative therapy. And here is the systemic corticosteroid. I think if for the mild ARDS, that is a PF ratio around 300, between 200 to 300. And for this patient, I don't think the systemic corticosteroid has a role. Maybe for the severe ARDS, there's a role. So I think it's very important not universally give the patient steroid. I know there's already published some paper from the UK is the recovery. They use the dexamethasone 6 mg per day for 10 days. But I think the patient population should be focused on the severe form. So even for the mild ARDS, in our here we didn't use the steroid because always concerned about the secondary bacterial infection. And we go into the mild to moderate to severe ARDS. The same principle for the non-protective ventilation, and can consider the higher PEEP. And because the issue of synchronize between patient and ventilator, we always consider use the neuromuscular blocking agent and recruit maneuver for our respiratory therapists. They can do daily or depends on the situation. And here is the prone ventilation for the evidence or suggestion they can recommend for the patient with severe ARDS. But I still to mention the issue for our experience. When the patient do the prone position, the secretion can drainage rapidly. So it's very important for our nursing care of this patient. They need to frequent suction the patient, but you still need a closed system suction. You cannot use the open system because we know when the patient intubated, the sputum is come out from the low respiratory rate. Those are trapped. So it's a very high burden of virus come out. So when you care the patient with prone ventilation, when do the sputum suction, always remember to use the closed system suction. And here about the short course of systemic corticosteroid. So as I mentioned from the UK recovery trial, I mentioned about the dexamethasone 6 mg. I think the 7 to 10 days, that's the duration. You cannot prolong use. For the prolonged use, always consider the risk of a secondary bacterial infection or a risk of under the steroid, the sugar, etc. Many concern of side effect. And here the antivirus, if you are available remdesivir, I think the timing is used as early as possible because we know the duration of the clinical course of the COVID-19. For the first, maybe the virus induced the tissue damage, and the second part is into the tissue inflammation. So here it's mentioned about chloroquine, but I think the hydroxychloroquine from the many clinical trials already show they no definite clinical benefit, but come out some concern about the especially arrhythmia complication. So right now here we didn't use a chloroquine. We in our interim guideline we didn't recommend it. And here is the interleukin 6 tocilizumab. We have experience use this. And depends on the severity and some information. So here we will consider from the biomarker, especially if the patient got very high level of ferritin or very CRP level, then we will consider use this. So because but it's a cost issue, so it's not every patient available to can use this. So here is some rescue or some adjunctive therapy, as I mentioned here, antiviral, anti-interleukin 6, etc. here. And here is talking about inhaled nitric oxide. We are available with inhaled medication. So if the patient got prone position and if they still come deterioration, maybe we can consider inhaled nitric oxide. And the next resort is the ECMO. So in our hospital, we are the referral center of ECMO center. So it's important, we always try the minimum of ARDS, even the prone position, but there's still a refractory hypoxemia. Then last result is a VV ECMO. But we still can consider the situation. If the patient got very severe septic shock and multi-organ failure, because not every patient can receive this ECMO. So I think we use a very strict criteria to consider which patient may be benefit from ECMO support. Not every patient can use it. I think it's the same problem even in the Western country or in Japan. I know that Japan, they use plenty of patients with ECMO, but because the care of the ECMO patient, they need very high labor and many devices, so it's very high cost. Sorry. So it's a summary about the management of the ARDS. So the baseline is the protective lung ventilation, and if the PF ratio is low, so you can consider the higher PIP, muscle blocking agent. As I mentioned, very few patients, if the PF ratio is very low, and you try everything you can do, even a prone position, and maybe we predict there's got a potential to recovery. Under that situation, then we find our ECMO team to discussion and consider use the baby ECMO. And another issue is how to intubate a critical care patient COVID-19. It's always the concern because, and then I searched all the information. There's no definite working definition, but I always mention intubated earlier in the course of the illness. So maybe you expect it for the same patients, if they got a bacterial pneumonia or they got SARS-CoV pneumonia, when the same clinical scenario, but maybe use the low threshold to intubate the patient with COVID-19. I think there are two concerns. One is we experience, especially for the patient, they got deteriorate oxygen, the course very rapidly. Maybe within hours, even half a day, they will progress to very severe. So if under very severe situation, and then you decide to intubate, then the staff or the ICU care team, they expose very high risk of exposure of droplets. And the patient, if they progress rapidly, the clinical outcome is not so good. But I find some working definition in some guideline they mention. So if the patient already you give the non-rebreathing mask or unstable vocal breathing, and the oxygen is still lower than 92%. Within the even either one oxygen supply, then you should consider intubate the patient. And I think it's very judged by clinical, but in summary, it's intubate early and within a low threshold for intubation. Then when you prepare for intubation, it's very important. It's a very high risk, we call it aerosol generation procedure. And you can see when the patient, if they're fighting, they're coughing, for the personnel, they try to intubate the patient. The person is very exposed to a high risk of contact the virus. So usually, it's always recommended the personnel wearing the personal protection equipment, and you should this should be done by the personnel with well training and experience, and especially in a negative pressure room. And then many devices, we already have a check-in list. So for his video assist, laryngoscopy, and other devices available. And during the intubation, I think every guideline was mentioned, do not try to ambulate this patient. When you ambulate, you use positive pressure. And the underlying situation, the spread of a droplet is very everywhere. So here is, and at the same time, you should use the rapid sequence intubation. So sedation the patient, paralyze the patient. And during the pre-oxygenation, we can use high flow nasal cannula, and or you can use the non-reversing mask. So it should not use the intubating. So it's very important if you intubate in the early stage and rapid sequence use with pre-oxygenation. And when you intubate, you use the video assist laryngoscope. I think it's a very reduce the risk of the personnel to do the procedure. And I mentioned for the mechanical ventilation, if you use the suction system, you always with the closed system suction, because the patient already intubate, and when you try to suction, you cannot disconnect the ventilator because during that time it's very, very high risk, because the pulse pressure spread out and the droplet come out. There will always contamination all around the room and for the personnel. So that's my talk today. I talk you from the respiratory distress and from the patient with acute respiratory failure, especially from hypoxia, or they got further deterioration, especially into the ARDS. Then what kind of strategy we should use? And I know I talk this is under very if the patient is not under the mass surge of a severe COVID-19 patient, but if the patient really come in a very mass critical care patient, I think the issue level is different. But the point is always think about protect yourself with the PPE, because you got good health, then you can take care of the patient. You not protect yourself, then you don't have the chance to take care of other patients. So I think very important, even under different scenario, always consider about well trained and protect yourself well. Okay, that's my talk today. Thank you.
Well, thank you very much, Dr. Shih-Chi for your nice and very complete presentation. I think we should proceed with the next speaker, so we have a more broader view on our topics today, and afterward we have another discussion then. So please, Dr. Dita, give your talk today.
Thank you, Dr. Ceva, for a very nice introduction. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. I would like to present the title of Intensive Care Management of COVID-19, Challenges and Recommendations. So as an introduction, this is our situations in Indonesia. Yesterday we have almost 3,003 new cases added to almost 165,887 patients that has confirmed has the COVID-19, which is in our country 120,900 died, and 10% of it were hospitalized in intensive care unit, and almost 72% of it dead. So this is our national guideline that was made by a multidisciplinary colleague in our country to overcome together the COVID-19 pandemic. So this is our national COVID-19 guidelines. So we all think that COVID-19 pandemic is one of the greatest challenges in the history of our critical care. As the COVID-19 spread across the world, the ICU unit community should prepare for the challenge. And the rapid diagnosis and isolation room, clinical management, and prevent of the infections was important, not only for the patients, but also for the healthcare workers. We know that the key important thing is the management of acute respiratory failure and the hemodynamics of our patients. So we, the intensivists, the hospital administrators, the policymaker, together prepare for a substantial increase of the critical care bed capacity, improving the infrastructure and supplies, and also improving the staff management. So we know that the collaboration at local, regional, national, and also international levels are important for the better chance of survival for our patients. So we know that when our patients get infected with the virus, along with the symptom of onset, the patient usually were given antivirals all together with the drugs that can boost the immune systems, and also all together with the anti-inflammatory drugs to reduce the immune system's response. We know that progressing with the disease, there will be a mismatch within the ventilations and the perfusions due to the intrapulmonary shuntings due to the edema and atelectasis, loss of lung perfusions, intravascular microthromby. And at this stage, our patient usually gets the medication for anti-inflammatory drugs. Some of the patients were positioned into prone positions within the awake condition and were given anticoagulants. As the disease progressed into respiratory disturbance, some of the patients from conventional oxygen therapy were intubated and put into the mechanical ventilation. And from all these patients, some of the patients, we also position the patient into prone ventilations using lung protective ventilations. And because the patient get the reduced lung compliance, the day space is increased, the consolidation and then atelectasis is also increased. The patient will get CO2 retention, and some of the patients will get anxiety and fatigue due to the high work of breathing. At this condition, sometimes we have to do the fluid conservative strategy to prevent the progressive of the edema, and some of the patients need additional antimicrobial to overcome the microbial infections with antibiotics. We know that after severe pneumonia due to the COVID-19 viral, there will be a very short release of systemic cytokine release from the infection, whether if the mediator is pro-inflammatory mediators or anti-inflammatory mediators, that all the release and can progress into the endothelial dysfunction, then can put our patients into the shock and further organ failure that could cause morbidity and further mortality. So this is the score that we use as an early warning score to decide whether the patients were highly suspected COVID-19 patients. We use the criteria from the chest X-ray or the CT scan, the history of a close contact with COVID-19 patients, fever, increasing age, gender, temperature, symptoms, and neutrophil lymphocyte ratio. If the score is more than 10, then we highly suspect that the patient had COVID-19. So further assessment for these patients, if the patient have a respiratory rate above 30 times per minute, or the saturation is decreased below the 93% with the room air or conservative oxygen therapy, or the heart rate increase above 120 times per minute, then we proceed the patient into critical care management. So this is what we do in our ICU as a part of the critical care management. We put the patient to non-invasive ventilation or high flow nasal canal. We restrict the fluid administrations. Some of the patients, we position the patient into awake prone positions to avoid further alveolar collapse. But when the disease progressed to more severe conditions, then we put patients into invasive mechanical ventilation. And we use the lung protective ventilation strategy using lower tidal volumes, lower inspiratory pressure. Some of the patients we put to prone positions. We use higher PIP, and some of the patients were indicated put into ECMO. So we limit the non-invasive ventilation and high flow nasal canal restricted only for mild ARDS conditions. You can see that this is our patients that use the high flow nasal canal, and this is also our patients. But some of the patients has to be put into ventilator, mechanical ventilator, and this is our staff using the full personal protective equipment altogether put the patient into the prone position. While this patient is on mechanical ventilation, we limit the tidal volumes to 6 milliliters per kilograms body weight. We limit the plateau pressure below 30 centimeter water, and we provide moderate to higher positive and expiratory pressure. And our patients was put into prone position for 12 until 16 hours in prone position. So this is our situation in our hospital. That this is our staff that perform the aerosol generating procedure during the intubation. We also do the CPR in our ICU with proper protection. We train our junior doctor, our resident, our junior staff, so they can be able to perform the CPR in a proper manner, such as using the PPE, back mask ventilation with filter, cover the patients with plastic cover, and perform the intubation in a proper manner. So the prone position, we believe that for the ARDS patients, the prone group, the patient who position in the prone position has a probability of the survival higher than the patients that only in supine positions. You can see that when the patients were put into the prone position, the chest wall elastance is higher during prone position. And we expected that the lung elastance is more homogeneous across the lung, like this, yeah. And also we expected during the prone positions, the aerations of the lung is also more homogeneous and well distributed. So we can get a result of better ventilations and perfusions matching with a better result due to the less intrapulmonary shunt compared to the supine position. So this is the patient that put into the prone position. The patient is still awake using the high flow nasal canal. So the challenge of using non-invasive ventilation and high flow nasal canal that we put the risk of the viral transmission to aerosolizations to our medical staff. So we should reserve this procedure to the mild moderate ARDS patients with airborne precautions, preferably especially in a single room with a low threshold for intubation of the patient. So whether this procedure or the intubation should be proceed, the person who performed the procedure should be the most skilled operator or the most skilled staff that should perform this kind of procedure, and using the full PPE and limited the aerosol-generated procedure. So what happened with the extracorporeal membrane oxygenator as the last resources for our severe ARDS patients, which is a very invasive, extremely resource intensive, even in centralized at designated centers. From this research, it shows that the ECMO prognosis is not so significant in COVID-19. We can see that the patient who's first planning to put the ECMO can survive without ECMO, about 3%, 3 patients. And the patient who's still alive with ECMO but not get better is around 4, and the patient who's immediately died is around 5. So that it is still not significantly different, especially in our adult patients compared to neonatal patients who underwent the ECMO, who get benefit from the ECMO for their respiratory problems. So this is our first patient that we proceed the ECMO procedure, which is a very tiring and extensive and a highly workload of the procedure. And we altogether proceed the ECMO altogether with the continuous renal replacement therapy in these conditions. When we're doing this procedure, there is a lot of complications that we have to face, such as heavy bleeding due to anticoagulant that we use a lot during this procedure to prevent the filter clotting. For the further clinical management is also we perform the infection prevention and therapy, such as blood culture, consider empiric antibiotics, diagnostic tests such as lactate. We cautiously give input to the patient. We use early vasopressor and inotropes drugs if needed. Some of the patients we give the corticosteroids. We perform the ultrasound to monitor our patients. And some of the patients, we put the patient to renal replacement therapy if needed. We put a light sedation protocol, enteral nutrition, blood glycemic control, and early physical therapy, together with all the management in ICU during the mechanical ventilation. We know that the hallmark of COVID disease, after the virus binds to ACE2 and TMP-RSS2 receptor, it further can correlate with the other receptor that can cause pyroptosis process that can release the cytokine and further damage associated molecular patterns release that can cause further inflammation, disruption of immunity, and coagulation dysfunction through impairment of activity of various immune cells. So this process is involved in the activations of the transcription factors such as interferon and NF-kappa B that could lead to bacterial co-infection, septic shock, and multi-organ failure, and then cause patients death. So this is what we do all together with the diagnostic and the treatment of the COVID-19, where by the time our patients were submitted to the ICU, we also perform the diagnostic tests such as radiologic examinations, microbiologic investigation. We took several culture from the blood, tracheal quantitative culture, to get a purulent sample of the patients, and then we give the patients empiric antibiotics according to our hospital epidemiology data, and we will assess every 48 to 72 hours with the biomarker such as CRP, procalcitonin, along the clinical response such as the fever or hypoxemia condition, to adjust the antibiotic therapies, whether we should escalate the antibiotics or we can de-escalate the antibiotics. So how about the hemodynamic management? The COVID patients often develop myocardial dysfunction in addition to the respiratory failure itself. So this is the monitor from our patients that we perform the echocardiography, and we suspect that these patients having the myocarditis. So we administer fluids cautiously we prevent the patient not to be hypovolemic, but also prevent the hypervolemic. And we cautiously assess the patient for preload fluid responsiveness. And we also regularly check the troponin and NT-proBNP and perform echocardiography to monitor our patients. So this is the study that suggests that we should very cautiously giving the fluid to our ARDS patients. The study shows that the best outcome can get if we give the adequate initial fluid resuscitation at the beginning of the course of the infection, and we perform conservative, more restricted fluid administration after the resuscitations resolve to prevent further lung edema and ARDS. And this is also a cohort observational study that can show the survival of the ARDS patients showed the less cumulative fluid balance compared the non-survivors that shows more cumulative balance during the ICU admissions. So we know that our COVID patients will undergo several stages, from the early infection stages into the pulmonary stages until the most severe of the hyperinflammation stages. Altogether with the progressing of the clinical symptoms from the mild symptoms into the more severe and to the most severe of the conditions such as ARDS, septic shock, and cardiac failure. And we have several options of treatments that's still in a trial, such as antiviral, convalescent plasma transfusions, IVIG, steroids, interleukin inhibitors, and also stem cell. So this is a study that shows that if we give an early low dose and short term of corticosteroid in our severe COVID patients, we will expect the increase of oxygen saturation in the early stage. But after the late stage, this benefit didn't show any significance. This is still the ongoing trial to use the dexamethasones for the COVID patients. And recently, we got a preliminary report from the United Kingdom that show that patients who already in invasive mechanical ventilation were significantly can get the benefit from administration of 8 milligrams dexamethasone for 10 days. Significantly has a better survival rate compared to the usual care patients. The other therapy is tocilizumab as the interleukin-6 inhibitor. We expected using these drugs, we can alleviate the symptoms and decrease the inflammatory marker such as the CRP and interleukin. The study that showed that we can use the dose about 8 milligrams per kilo body weight, and we can repeat it, the administration of the drugs within 12 to 24 hours if the symptoms is not improving. This study showed that the impact of low dose tocilizumab can significantly improve the survival of the patients. This is our patients that are very high interleukin that we gave the patients tocilizumab, and this patient had improving oxygenations at that time. So it is very advisable to perform the diagnostic test such as CRP or the level of interleukin-6 before we give the tocilizumab as an anti-interleukin-6. And what we expected from these drugs, we can decrease the ferritin level, the CRP protein level, and the level of interleukin-6. So we can decrease the rate of mortality of our patients. However, recently, last month, one of the industrial company who produced the tocilizumab reported honestly that this product were considered cannot meet the primary endpoint of improve the clinical status of the phase 3 of this tocilizumab. The difference of patient mortality, the time of hospital discharge, and ventilatory free days were not difference between the patients who got tocilizumab or the patient who did not get tocilizumab. So about the convalescent plasma therapy, from this study we can see that only this subpopulation of these patients, severe disease for subpopulations, they can get the benefit of the convalescent plasma therapy significantly compared to our ICU, who is very severe, very critical, and almost life-threatening conditions. And our patients in this condition, between the patient who did not get the convalescent plasma and the patient who get the plasma convalescent, could not show any significant beneficial. Maybe it's because in our very critical life-threatening patients, there is a lot of factor that could contribute to the outcome during the plasma therapy. So how about the IVIG? IVIG were expected to improve the body defense, block the receptor that associated with the targeted cell, and prevent the virus from further damaging our patient cells. But what we can see from the study, the survival from the patient who get the IVIG was higher in the patient who get the early IVIG less than 48 hours compared to the patient who get the IVIG later on after the 48 hours. So we should consider the IVIG therapy earlier than later on. So how about the inflammations of NCRT, continuous renal replacement therapy? We know that during the sepsis and inflammations, there is a theory that the pro-inflammatory peak and the anti-inflammatory peak that can happening all together or alternate to each other. So that could be misleading to us whether we have to give the anti-inflammatory drugs or whether the pro-inflammatory drugs. So the continuous renal replacement therapy is one of the mechanical procedures that can help us to overcome, to reduce the mediator, whether the pro or anti-inflammatory condition, not depend on whether the patient has alternate peak or altogether peak at the same time. So this is the study that can show that the CRRT group have a better survival compared to the group that did not receive the CRRT groups. What happened to the non-survival, although the patients still receive the CRRT, there are some parameters that can contribute to the patient that cannot survive even the patients receive the CRRT, which is older age, the level of interleukin-1, interleukin-2 that cannot be decreased during the CRRT, and the patient who had a sustained level of troponin I and anti-proBNP from the beginning until the later on. So those patients still cannot survive. And after the infections, we know that activated the ACE2 receptor. The ACE1 receptor will shed and rapidly increase the mediator of the M2 that have a positive feedback and increase the inflammation and the coagulation factor So what happened is an increased leukocyte infiltration that can cause a further endothelial dysfunction. If this process going any further, then the patient will fall into the more extreme physiologic level, that from the vasoconstrictive level, fall into the further microvascular dysfunction, and the patient can fall into a severe vasodilatory shock later on. So the infection not only promote the excessive immune response, it also activate the system that can prone to endotheliopathy and hypercoagulopathy that can further put the patient in more hypoxia due to the microthrombosis and microthrombosis. So the recent guideline suggests us to use the venous thromboembolic prophylaxis earlier in our patient, because from the autopsy from our COVID patient, 58 patients have the pulmonary emboli, and cause of the death is almost 33 due to the pulmonary emboli. And in our COVID patients, 39 patients, 20% were diagnosed with vein thromboembolism. So it's really advisable to start the anticoagulant such as low molecular weight heparin or unfractionated heparin in all moderate to high risk patients, unless there is a contraindications to give anticoagulant. So how about the nutrition? The feeding should be initiated with low dose enteral nutrition with the target to meet energy goals around 15 to 20 kilocalorie per kilogram body weight, which it should be 70 to 80% of caloric requirement. And we should aim for a standard high protein, and some of animal models and a few small studies suggest that the fish oil containing formula may benefit in immunomodulations in our ARDS patient. But of course, we still need further study for it in our COVID patients. This is one of our patients, that the survivor of our COVID patients. COVID patients, even the survivor, they need a long recovery time to get fully recovered and can go back to his previous condition. So the rehabilitation program is very important for our patients. So this is our patients that can overcome the COVID-19. So we have a program, the intensive program for rehabilitation to promote the recovery of these patients. So how about the ICU donations? We have a designated infectious ICU that receives the patient from the ward, emergency unit, elective operating theater, or other ICU as a containment of the suspected or confirmed COVID patients. So after the patient was suspected or confirmed with the COVID-19, we admit the patient to our negative pressure ICU. This is an isolation room with a negative pressure, or some of the patients put together in the same room and only put in a cohort bed space apart in the ICU, because we have a lot of bed available sometimes due to the overload of the patients. What's the challenge? Sometimes the isolation room with negative pressure are not immediately available, especially in resource-limiting settings. Even in high-income countries, they also have a problem with insufficient ICU bed. So to overcome the situation, sometimes we use a single room without negative pressure, or cohort the cases in shared room with bed space apart. Then also we also try to augment our staff competency. We'll give the appropriate training to take care of our COVID patients. Of course, with assurance with the staff to strictly do the infection prevention, limitation of the shift hours, and we also support the mental health of our staff. So this is our negative patient ICU in our hospital. For the specific consideration, most of the therapy in COVID-19 is still on trial. So some of the patients, we inform the family to be asked to participate for the therapy in clinical trial setting. So our hospital also do some research such as stem cell therapy, also doing the solidarity trial and plasma convalescent therapy. And the last but not least, we also taking care of the end-of-life care in our ICU patients using the score and the checklist for palliative care. And we promote the communications using virtual technology with the family and support the family. As the conclusion, the clinical feature of COVID-19 patients sometimes are not specific and not easily to distinguish and to manage. And the ICU practitioners should increasingly have a high index of suspicion, and we should have a reliable diagnostic testing for it. The role of non-invasive ventilations, high-flow nasal canal were increasing, but the various experimental therapies and still under investigation. A substantial increase in critical care capacity or risk being overwhelmed by the pandemic, it's still increasing and we'll still face it until now. So we have to focus on infrastructure and supply, staff protection, and promote of the mental being of all the patients, family, and all the staff all together. Terima kasih. We would like to thank to everyone who's taking care of our patients. Stay safe and healthy. Thank you.
Okay, thank you very much, Dr. Dita, for the most comprehensive and complete talks on our discussion today. And I really saw that we have a lot of information, new information today for everybody who's attending in this session today. So I would like to open the discussion for the two speakers. There is questions already. First, please, Dr. Koo, answer this. The first question is, why an IPVV is not recommended for hypoxia COVID-19 patient? What if the facility do not have any ventilator or a high flow nasal cannula? Could we still use the NIPVV? And the second question maybe, do you routinely doing the position, prone position for the patient with moderate to severe ARDS? And also I would like to ask your experience maybe in a non-ventilated patient. In a non-ventilated patient, do you do the prone positioning? Do you think that it's going to work in a patient without ventilator yet? Please, Dr. Koo.
Okay. For the first question, as I mentioned, depends on the scenario. If you have a very slow, you don't have a mass surge of COVID-19 patient, then maybe you can just use, as I mentioned, use the simple nasal cannula to non-rebracing mask. And next follow the patient, if they got rapid deterioration, in my suggestion, we'll switch to the invasive mechanical ventilator. But if under the scenario is a mass surge of all the COVID-19 critical ill patients, and you don't have so many available high-level mechanical ventilator, I think it's reasonable to use the NIPVV as a bridge. Because from the study, yes, there's some patients really they can support with NIPVV, they got improved, got recovery. There's no doubt. But as I mentioned, there's two scenarios possible. First, if you use NIPVV, some certain of patients got a chance of delayed intubation. They got worse outcome. This is one concern. Second concern is I don't know the availability of the mask, because I know in Italy they use the helmet. The helmet mask, I think it's very quite easy, because use the helmet mask is very low risk the spread of the virus. But if you use only the simple mask, I don't know for your experience, sometimes the patient, they were fighting against the ventilator, the non-intubate. So maybe is the mask not so fit. So you still need some step to take care of a patient. So there's some concern, always a concern, the spread of the COVID-19, the droplet. So my suggestion depends on your hospital. You need to make a contingency planning. If the patient is the patient flow, severe patient is not a mass surge, maybe I will suggest step by step. But if the patient they still got mass surge or go into the hospital, there's no chance you can intubate every patient by low threshold. So in that scenario, the NIPBB should be used. But the two concerns I mentioned, you should always to consider, because your staff, as you mentioned, the staff healthy is very important. You need to maintain the intensive care manpower steady as long as possible. And about the second part, the prone position, for in general, if we talk about ARDS patient, that is for any possibility pneumonia or from pulmonary or extrapulmonary origin progressing to ARDS. In my institution, we always do prone position first, because from the evidence, I think the previous speaker mentioned the Ceva study. It is in French. I think it's very, very striking, consolidated evidence show us that for the moderate to severe ARDS patient, always try the prone position first. So in our institution, it's a regular protocol for medical intensive care unit. But in the COVID-19 patient, as I talked in my lecture, there's some concern about when you do the prone position, the circulation drainage will come out relatively higher. So in that scenario, you need to take care, respiratory care about the sputum suction. So in that situation, it's always very concerned. Always be cautious for the nursing or medical or doctor to take a patient. Even I look at your picture, you do the percussion. I think the situation in that situation is come out. Then you need to be cautious in that situation, any concern or spread of the droplet. And I know from your lecture, you mentioned about awake prone position. We didn't try this in our institution because I think you didn't know which patient, when if you got awake prone, and if something happened, then you need to maybe do the resuscitation. So you need to supply again, and in that very rush or very critical situation, maybe you need to do a rapid intubation or something wrong. So I think we talked about this issue in our institution. For very practical issue, we didn't recommend for our patient do the awake prone position. Yeah, that's my answer. Yeah, thank you.
Okay. Do you have any contraindication, especially the complete contraindication for prone position? You won't do that in what kind of patients?
I mean, you didn't do prone position in what kind of patient? Oh,
yes.
I know for the Ceva study, even the patient with hemodynamic unstable, they still do the prone position. But in the real world, in our experience, if the patient already got maybe a stable hemodynamic, especially if they got a septic shock and they already receive a very higher dosage of vasopressor. In our experience, we are very concerned about when you do the perposition, the position change, the hemodynamic change rapidly. So there's no way to, when you do this way, if something happens, it's very terrible. And second one is patient with very devices on their body. For example, with a patient with CRT, and we use your cannula from the femoral site. So you can think in that situation, if you probe this patient and if do the same time with the CRT, if the device is a cannula in the femoral site, it's very, very difficult to do this in a patient with ARDS thrombus and with the CRT. So it's very practical. We concern about the patient risk and the care of the patient. Even the paper tell you, okay, just try your best to do the proposition. But I think with a practical issue, we should look at the patient safety in these two parts. Yeah.
Okay, thank you, Dr. Ku. Let's see for another question available. Okay, the next questions are first for Dr. Dita. Which steroid you use for COVID-19 patient with severe ARDS? What about the dose and also the duration? And the other question is, do you have any experience of using point of care ultrasound to assess the ARDS of the patient?
Thank you. After the study from United Kingdom that they successfully using dexamethasone 6 milligrams for COVID patients, and the result it's kind of promising. Then we moved from the steroid methylprednisolone 1 milligram per kilogram body weight into the dexamethasone 6 milligram for 10 days for our COVID patient. Also, we have to be cautiously assess the patient because we know that the steroids can increase the risk for infection, can increase the level of blood glucose. So we have to strictly control the glycemic level, and in some patients can create imbalance, electrolyte imbalance, and can cause polyneuropathy if we use the steroid for a long time, such as like it. So we move from methylprednisolone 1 milligram per kilogram body weight into the dexamethasone 6 milligram for 10 days only.
Okay, the second question about the point of care ultrasound. Do you use it to evaluate the lung condition maybe, or the IVC maybe?
Yeah. We the intensivists usually perform the focus using the ultrasound to daily monitor our patients. Like a simple ultrasound for look the IVC, lung ultrasound such as a beeline, or maybe the pneumothorax, such as like that. We also have a team that could help us from pulmonologist team and cardiologist team that we can consult them to help us to monitor using the ultrasound for the lung ultrasound and the echocardiography. But we're the intensivists, we also perform the like eyeballing ultrasounds to see the performance of the cardiac, for example, daily using the ultrasound, the echocardiography. But of course, we consult to the more expert pulmonologists and cardiologists to confirm our assessment daily.
So, Dr. Ku, do you have any comment on these two issues, the dexamethasone and also the use of ultrasound?
Okay, for the first steroid, as I mentioned before, you know that the UK recovery trial is a preliminary result. So I look in detail about the adverse event, as I mentioned, because the side effect infection or any sugar control issue, etc. I think the interim preliminary result didn't show you the complete whole picture. So you can look at the past medical literature, especially the virus-induced severe ARDS patients. If you use the early use of steroid, it's always show you, especially for influenza ARDS, it's always show you a very, very bad outcome. So I'm a little bit concerned. So you will restrict usage of the dexamethasone steroid, especially only in the severe ARDS patient. For the little bit mild to moderate, I think for the present our care skill, I think we can handle it. But for the very severe ARDS patient, as I mentioned, if it's possible to measure the interleukin-6 level, I think it's not. We try to measure, but it's not come out by daily basis. So I would suggest we use a little bit of biomarker, etc. Very high CRP level, and they didn't have any sign of infection, and especially the ferritin level. It's a very important, a little bit secondary mediator referred to the pro-inflammatory because it is driver for interleukin-6. So combine the biomarker with severe ARDS, exclude any co-infection when you see the patient. Yeah, I would suggest early use of dexamethasone. But beyond that, I will very, very conservative because always concerned about the infection. And for the second part, the focus, we will use it especially for the IVC collapsibility. And but for the cardiologist, because we have other invasive hemodynamic monitoring, for example, we have PICO, or even some patient with a strong gun. So it's a very real-time measure the hemodynamic monitoring. So because if put so many patient doctor into the care room, still expose a risk of infection. So if that patient need a hemodynamic monitoring, then we put a PICO or even strong gun to give the data with cross monitoring. For other part, I know some literature mentioned even you didn't take the chest X-ray, you just use the lung ultrasound by the A-line, B-line, etc. to reflect to the severity of ARDS. But I think because they are concerned the issue about the inter-observer variability and the echo window, maybe not so many patients can have the same picture. So in that scenario, we just use the chest X-ray and by the lung mechanics from the ventilator and from the artery blood gas to measure the lung condition. Yeah, that's my answer. Thank you.
Okay, thank you very much. So we'll see another questions. The question is, do you experience ventilator scarcity in the hospital? How do you manage to choose which patient got intubated and ventilator? I'll start with Dr. Koo first. Do you have any comment on the ventilator scarcity?
Yeah, I know. We know the very, very sad story from the even the news, or even from the Italy or some United States, because when the mass surge of so many COVID-19 patient, then you have to consider triage of the patient. I know some because we don't have the issue because we don't have the because I think we are border control, wear mask, social distancing, we do a good job. But we in our colleague or government always think about the issue. If the situation really happen, what we will do? You have to do triage the patient. I think it's very yeah. In the reality, if this situation really happen, we need to try it to the patient. But what criteria? As I mentioned, if the severity score and the age, and I think the SOFA score may give you some information, because if a patient got very extremely higher predicted mortality, and by the way, there's some certain patient got moderate severity, little bit young age, little bit less comorbidity, then you have, by reality, put your resources to this kind of a patient group. So we talk about if this really happen, triage by age, by comorbidity, by severity. If very, very severity patient, they got a very higher predicted mortality, you have no chance because you have got a scarce resources. Then in that situation, maybe you cannot try this. So in that situation, maybe, as I mentioned, the non-invasive ventilator, maybe for this the patient. But for the really need patient, you got a very aggressive intubated patient, got a full facility. So I think yeah, it's very in reality you do think about it. But in our current discussion, we don't recommend one patient, multiple patient for one ventilator. I know there are some already some, even in a Western country, they do very fancy one computer how to connect to the different patients. But we talk about ourselves, in reality, it didn't work because the different patient, a different lung mechanics, different issue of a ventilator function. If you got this situation, if one ventilator got dysfunction, you got multiple patients got worse condition. So in our society or in our country, we don't recommend multiple patients for one ventilator. So that's my answer. Thank you.
Okay. How about you, Dr. Dita? Do you experience of any lack ventilator, and how do you overcome about it?
Thank you, Dr. Ceva. Of course, in our hospital, even before the pandemic, we have this kind of problem. We have a very limited ICU bed and also the ventilator available. Especially after this pandemic happened, of course, we have a very such cases and very high problem with it. So what we're doing, we try to make a priority to accept the patient. First, if the patient was admitted from the emergency, usually the patient who need the ventilator get intubated first. Because if we use the non-invasive ventilator, we should observe the patients closely. Sometimes in the emergency, we don't have too much staff enough to monitor closely for the patient. So usually the patients get intubated and put the emergency. So that's what happened in our isolation room in emergency. Sometimes we have a lot of patients get intubated and waiting on the line to get a bed ICU available. And secondly, we collaborate with the high care unit. With the high care unit, they can use the non-invasive ventilator and high flow nasal canal for these patients until the patient can get ICU bed available for those kind of patients. Sometimes in the high care, we intubate also the patients and put the patient in ventilator for a while, and after the bed ICU available, then we transfer the patients to our ICU. And then third, we use some score to make a priority whether the patient should be intubated or should be admitted to the intensive care or high care unit. We use SOFA score, we use the logistic organ dysfunction score, and even we use the palliative score to screen whether the patients get the most priority to get our ICU bed. And the fourth, which is we really don't want to do this, we refer our transfer our patients to another hospital, which is sometimes it could put the patient into more problems, another problem to transfer to another hospital. That's what we're doing.
Okay, thank you, Dr. Dita. As we are talking about the burden of the patients, there are many patients we have to face. I'm sorry, I want to take time a little bit to get out from the ICU. I understand that Taiwan is one of the country maybe has the success story on controlling the pandemic. I hope this is true. So, Dr. Ku, can you tell us how is your country policy on facing this pandemic? Because we are increasing problems here in Indonesia.
Yeah, I think if you look at the story from very early this year, I remember maybe the January or February, because we are very close from this day to the mainland China. So we at that point we got very quick strict control, that is abandon the traveler from the China into Taiwan. Is the first. It's a very strict that we call it border control. So for the patient, even outside the other country, we will look at we will stratify the situation. For example, in the area for China, we rated is a very higher epidemic area. So even for the country, we abandon they come into. And for stratify different countries, so the border control is very, very important. And second one is in our country, I think we are very familiar with this kind of infectious disease because, for the SARS 17 years ago, we already have experienced that if you didn't control in your community, for example, the wear mask or social distancing, we know it's a very, very important issue. So in the very, very early on, even in February, we already have wear mask and social distancing, and especially when the patient go to the clinic, we already set up the fever clinic. Depends on the travel history, depends on the risk. So even the patient from outpatient to see the doctor, we have some resort refer to the special clinic. They do the evaluation, they do the virus testing. So it's very important you didn't very detailed to look at every patient. So even the patients imported, then we have a policy. Even imported patient, they have to self-quarantine for 14 days. So even the low-risk country, they come from in our airport into our country, then you have to stay in certain area for self-quarantine. It's very important that because even you got asymptomatic or any, but during the 14 days quarantine, the spread of risk is very, very decreased. And third one, I think is very important. Even the community, because the very few cases, even the community happen, then we can contact tracing in very, very detail. So our government agency, they tracing for this in that case around him or her. Every patient, they do a very detailed contact tracing screening and test all these patients. So you can see we are not, our policy is constrain the virus going to our country. We didn't do only in some countries mitigating. They see, okay, already some community spread, we just mitigating, but we don't do that because we control very well. So every case counts. So we do the very, very detailed tracing. Then even some concern, you need to self-quarantine at home. And of course, I think maybe for different society belief, I think in our people here, they always believe, they know that from the experience, from the SARS experience, if you didn't follow the government's rule, then will terrible thing happen, like 17 years ago. So I think for this experience, the memory, or I think our people here, they will follow the rule by the government. Okay, some regulation, and because you didn't follow it, we have some punishment at the same time. So I think it's very important for our government, for our people, and everybody unite together to facing this pandemic COVID-19. Thank you.
Okay, thank you. So we'll see another question. Is there any other? Okay, there are two other questions. First, how do we stratify the risk of thromboemboli in COVID-19? And the other question is, do you give micronutrition supplementation such as vitamin or minerals to patients? I think I'll ask the Dr. Dita.
So we stratify the risk of VTE with VTE score. If the score of above 4, then we know that this patient have a high risk of thromboemboli. So we immediately give the patient anticoagulant for this patient. But since we sometimes we know that one of the main pathophysiology in this COVID-19 is microthrombic. So most of the ICU patients, as long as there is no contraindication, we immediately give anticoagulant from earlier from the first time to prevent the VTE before it happens, no matter how high the score of the VTE score it is. We can use the low molecular weight heparin or the low fraction of heparin, or if the patient is not intubated or already extubated, we switch the anticoagulant from the IV anticoagulant to the oral anticoagulant, something like that. So the second question is...
the second question is about the vitamin and mineral.
Yeah. When we receive the COVID patients in our ICU, we immediately collaborate with the clinical nutritionists in our ICU. So we follow, there is a protocol that we give micro and macronutrients, such as we consult with them how many calories, how many proteins that we should give. And for micronutrients, we immediately give the vitamin C, at least 2 grams per day, zinc, at least 1 milligram per day, vitamin D, at least 5,000 units per day, vitamin B complex, at least such as like a thiamine for 200 milligrams a day, and sometimes we give another supplements such as
zinc, maybe.
Zinc, yeah, zinc. We already mentioned the zinc. From 10 to until 40 milligrams a day. We don't routinely give selenium in our patients.
So, Dr. Q, do you give a vitamin or other supplement for the patients?
I think still we follow the guideline of sepsis management. I think for COVID-19 patient is not so different. So for the first 5 to 7 days, we try the interior feeding. So, but some patients maybe didn't feed well. So you can just give the traffic feeding. It's okay. But if the time passed to the 7 days later, they still not get very well from the interior feeding, then we will try, our interior feeding. Then at that time, I think we call it the trace element. For zinc, etc. And the multivitamin, vitamin C or some vitamin B class, that we will supplement at that time. But we didn't give very early, just for example, the day 1, the patient admitted to ICU, just give it. We just follow the sepsis guideline mentioned, try interior feeding. vital safety status still not, even now didn't work very well. We tried power intubating. At that time, then you still supplement all this material. And so we just not so particularly another protocol for the COVID-19 patient. We just follow the same condition for all the even COVID-19 safety patient. They follow the safety guideline tell you. Yeah.
Okay, thank you very much, Elsie. So there's no other question, I think, because the time is up. I think we have had a lot of talk and discussion and very fruitful discussion today. We learned a lot of many information. We have to intervene the patient in low saturation, especially in 93 of saturation oxygen or below, and we try to give non-invasively first, especially with the high flow nasal canal, and try not to use the NIV or NIPV, and then we have to do intubation. Try not to be late to do the intubation, and then we have some things that maybe can do for the patient, but all are still in observation because they are not concluded the best treatment, I mean the definitive treatment for the COVID-19 yet. Okay, thank you very much, Doctor, for the time. Thank you for the NTUH for the joint seminar today, and all of the crew in Cipto Mangunkusumo Hospital, also Dr. Dita. So I'll close the discussion. So I'll give back the time to the MC. Please, Dr. Abi.
Okay. Thank you, Dr. Ceva. Thank you, Dr. Ceva. Finally, we have reached the end of this webinar. On behalf of Dr. Sri Martani, we would like to say thank you for Dr. Shih-Chi and all the NTUH committee. Dr. Ceva and Dr. Dita, thank you for the fruitful discussion. And before closing, we would like to show our next webinar with the title of Mental Health Support in COVID-19 Pandemic, which will be conducted at September 19th, 2020, with the two speakers, one from NTUH and one from our Department of Psychiatrists. And we hope to see you again in the next webinar. Thank you very much. See you online. Thank you.
好，你先准备说，他slide.
Kalau saya lihat ya dari, oh bukan itu.